Good morning and good afternoon, everyone. Welcome to today's webinar session from the Maternal Health Learning and Innovation Center. We really appreciate you joining us today. My name is Alice Pollard, and I'm the training coordinator with the Maternal Health Learning and Innovation Center. As many of you know, the Maternal Health Learning and Innovation Center is a new national resource center with several collaborating groups that is developed to accelerate innovative and evidence-informed interventions that improve maternal health and eliminate maternal health inequities. I'm just going to start off today's webinar with a little bit of background information and then a little bit of logistical information. As many of you participated in our webinar last week know, this month we have organized several virtual opportunities to talk more with maternal health advocates about telehealth. And this is the second of two webinars that is featuring healthcare providers, talking more about how they have incorporated telehealth into maternal health care. Today's webinar features Lana'i Community Health Center, who created a telehealth program for prenatal care with primary care really in the driver's seat for program development. They've got a lot of practical tips to kick off the conversation, and we'll also have a lot of time for Q&A at the end of the presentation. And I'll introduce you to our two speakers today in just a moment. In the audience, we have maternal health advocates from across the country joining us. Many of them are HRSA-funded state maternal health innovation and RMOMS teams, so we welcome them and all of you to the webinar. Throughout the series, we hope that you'll take a better understanding away of how other programs have incorporated telehealth into maternal care and take away some ideas for your states and regions. I just wanted to go over a couple of housekeeping reminders today. We will be recording today's webinar, and we will share the recording after today, as well as the recording from our previous webinar. All participants will be muted, but that certainly doesn't mean that we don't want to hear from you. We will have time for question and answer at the end of the presentation, so please use the Q&A box to enter questions. We will also have a very short evaluation survey for participants that you will see links to at the end of the webinar. So we hope you will complete that survey and let us know your feedback about the presentation. The Maternal Health Learning and Innovation Center is really grateful to be supported by the Health Resources and Services Administration, or HRSA. The information or content and conclusions of this webinar are those of the presenters and should not be construed as an official position or policy by HRSA, HHS, or the US government. So one of the things that we like to do at the Maternal Health Learning and Innovation Center is share with you all some reflection questions as you go into webinars or other training engagements that we hope will help you as you are processing what you've heard today and share it with your teams. So if you are so inclined, feel free to take your phone out and take a picture of this slide or take a screenshot. So we've put together 5 questions there that we hope you can take with you to reflect, and we'll show these again at the end of the presentation so you can think about this webinar and how you may share it with the folks that you work with and other people in your community. So I'm going to introduce our speakers to you all and then turn it over to them for their presentation. We are so grateful to have them share their experience today. We had a great phone call earlier in the last month where it was so wonderful to hear about their program and how they've approached their work. I think they've got a lot to share. So we have 2 folks joining us today. Dr. Joe Humphry is a medical provider with a focus on chronic disease. He has been the medical director at LCHC since April 2013. He has a special interest in diabetes, and he is a primary internist that has worked with the FQHC healthcare system for more than 25 years. He is a graduate of the University of California at San Francisco School of Medicine. And he has shared with me that he has a particular interest in technology in healthcare, which date back to the late 1980s when he programmed a diabetes registry for the Hawaii State Diabetes Control Program. So we're really grateful to have him here today. And also joining us today is Jared Medeiros, who is the Associate Medical Director at LCHC, where he joined as a primary care provider in December 2014. He completed his nursing degree at Manoa and the Master's Entry Program into Nursing, and the Master's Program in the Family Nurse Practitioner Program. So I think I'm turning it over to Jared. Thank you so much, both of you, for joining us today.
All right, thank you. Good afternoon, everyone. Grateful for this chance to share the things that we're doing here at Lana'i Community Health Center. We can do the next slide. All right, so just an introduction on our island here in Hawaii. We are the smallest, I guess, populated island of the Hawaiian Islands. We do have a history of being known as the Pineapple Island. James Dole, so Dole, kind of Dole pineapple was kind of the crux of Lana'i and its growth of where it is today. The last harvest of pineapples was in 1992, and since then the island has kind of transitioned to a hotel tourism based kind of focus here on the island. Our population is of 3,100 people, and it's a pretty diverse population, mostly Asian, so about 53%. And then we have a small population of some Pacific Islanders, 12% Hawaiian, and about 5% of some Pacific Islanders from Costa Rica. Over 40% of our residents are Filipino. Very rural island. There's only 30 miles of paved road, and everybody lives in the center of the island, and the rest of the outskirts of the island are uninhabited and are primarily dirt roads. Primarily for residents, they primarily fish, hunt, and there's empty beaches. Very rural compared to the other Hawaiian Islands, where it's very, I guess, urban focused, and Lanai is very rural in that sense. Everybody lives in one part of the island, and the rest of the island is uninhabited. About our health center here, so we're a 501c FQHC. We provide services to 60% of the island population, and we focus on integrating our medical, dental, behavioral health, and optometry services all together. We have around 40 employees. Most are hired locally from the community, and most are full-time and live here on island. The medical team includes our medical director, Dr. Humphry, so he's a quarter-time MD. We have 3 family nurse practitioners. We have 1 psychologist full-time and 2 part-time psychologists and 1 part-time registered dietitian. In 2018, we had 2,000 unduplicated patients and had about 9,300 visits, and we are about the same this year. Of course, COVID has kind of changed those numbers a little bit, but we provide about 30 to 35 patients a year for prenatal care. And so that part of our care has expanded immensely over the past couple of years since we started this program. So our TELE program is offered to every patient. If they want to participate, they can choose. Some patients have previous relationships with other obstetricians that they have on other islands that they want to continue with, but we offer it to every patient. And the benefit to this is that we can really try to keep our patients here on island. So we have a relationship with an OBGYN, so by sharing this program with the patient, and if they want to participate, we provide them with that OB's kind of new patient forms to complete, and then we schedule around the tele-OB schedule. And often when we're communicating with the obstetrician that we have a relationship with, we can just schedule directly with them for follow-ups and anything else that may be needed. Our program is very unique in that we as the primary care provider are kind of in the middle of this prenatal, postnatal care with the OB. And so, oh, sorry, we can go back one. Perfect, thank you. So how we facilitate doing these telemedicine visits is we use Zoom, just like how we're doing now, and the obstetrician will join on, and the PCP is in the room with the patient and the OB on the computer, and our medical assistants, do the normal check-in, everything here at the health center, all the vitals, any labs that may be needed. While we're in the appointment with the tele-OB, the primary care provider will measure the fundal height, we'll get the fetal heart rate, and the OB is on there on the Zoom kind of observing and just being a part of the visit to answer any questions. The PCP is kind of also at the point of contact for the patient, to kind of help communicate with the OB to express any of their concerns or questions or desires for their labor and delivery. and the PCP and the OB can kind of work together to schedule the next visit. So this relationship has really allowed the patient to really feel comfortable coming to our clinic here and getting their prenatal care, and just limit the need of having a patient to leave island for getting certain care. And the OB is kind of also there to help schedule anything that needs to be scheduled on Oahu, one of our major islands that our patients choose to deliver on. For example, if a patient needs to get a genetic counseling, or a nucleotranslucency scan, or further testing, or a fetal echo that we can't do here on island, the OB is able to help kind of facilitate that on her end. So we just wanted to kind of start off to kind of prime the pump to sort of say, what's the big deal of what we're doing here, for this program. So we're going to start out with a case study. Our population being predominantly Filipino, we do see a high volume of diabetes and hypertension. And so here's a perfect example of a 41-year-old female who already had diabetes, who was hypertensive, and she had a high desire to become pregnant. And so we kind of go through a timeline here of how things kind of worked out. So we started to give her some education about, where she's at with her chronic disease and how that relates to pregnancy. We got her started on monitoring her blood pressure and monitoring her glucose. And we got our community health workers involved to kind of work together with the patient to help facilitate those gathering of blood pressure and glucoses. We got our dietitian on board to help with education, and we had her come in when she had a positive pregnancy test at home and got to kind of initiate that process. Dr. Harai is the TELE OB that we kind of have a relationship with, and so we're able to easily text and call her to say, hey, this is what I got going on, anything that we should kind of keep in queue for her, anything we need to do in the meantime. And so it was a chance for us to have a 20-minute discussion to help coordinate her care. And for the coordinated care, how we facilitate doing our prenatal care visits is every other visit will have the TELE OB involved in our prenatal care. So the initial visit was with Dr. Harai, our TELE OB, to kind of start that process of having the OB involved in the first trimester. And then subsequently, we'll alternate the visits between the PCP and the OB involved. And this was able to help facilitate the patient getting appointments on Oahu to get further testing and things that would be needed at her age due to her high risk. Also, we were able to do ultrasounds here at the health center with technology to send images remotely to be read by maternal fetal medicine physicians. And our TELE OB was able to communicate with the diabetes maternal fetal medicine specialists, and the patient was able to give birth to a healthy baby and return back to Lana'i. So again, we couldn't have made this possible without the communication coordination between our telemedicine OB providers. And so here's another example of kind of the other spectrum, the very low risk kind of pregnancy. So this is a 31-year-old Asian female, so we can do all the prenatal labs here. We can do the dating ultrasound. She didn't really have a need to have the OB involved right away, so sometimes it just works that way with scheduling and things when they come in to see us. And so the initial TELE OB visit was in the second trimester. And the one unique thing about our island is that mothers aren't able to deliver here on island. So patients have to choose between going to Oahu or Maui, and that's where they would deliver. And so we usually recommend that they make that transition to the other islands around 37 weeks. And so kind of more to why this program is really beneficial for both of these patients is it really reduces the need for them to have to leave their family and go and get care on another island and come back home. So we really try to facilitate keeping our patients here on island. So again, this healthy patient was able to remain here on island the entire time until she had to transfer at 37 weeks to deliver, to a week delivery. So I guess the value for primary care providers, myself, would be the team-based approach. When I first started in 2014, we did not have this program, and as a rural healthcare provider, you feel really isolated. On my island, there's There's not an OBGYN. We do have an acute care hospital with an ER that stabilizes and ships patients out to other islands where they can get a higher level of care. So having that team-based approach where I'm no longer kind of left on my own, I have partners, you know, OBs, tele-OBs that are a part of the care of the patient can really help, just immensely help the provider, help the patient. And this partnership with the specialist is really, really important because it allows that specialist to have a invested interest in the outcome of the patient. And it helps the patient, you know, understand that their primary care provider has a relationship with the specialist, and it's just all connected, and it really helps the care that the patient gets. And it really helps to know who the provider is that we're working with. Oftentimes in the regular kind of medical world, when we create a referral, we send it off and we kind of wait for a fax to come back with the report of the evaluation and things. But having the knowledge of who's involved with their patients, we're involved with the appointment, it allows the PCP to develop this relationship with the specialist to help the patient get the care that they need. And our patients are very grateful for the program to know, you know, who's going to be delivering their baby. They can stay on Lana'i. They don't have to leave the island unnecessarily. And it definitely helps the patient be compliant with the things that we're talking with them, because the primary care provider is involved and we know the treatment plan and what is in place. And then I'll turn it over to Dr. Joe.
Dr. Joe.
Thank you, Jared. Yeah, I very politely put myself on mute. I wanted to start off sort of with a 30,000-foot look at where we've been as a health center, and you know, one of the aspects that is important is determining outcomes, and this is a common graph that is often emphasized, and a lot of focus has been on social determinants of health, which obviously our population has a disadvantaged population, and rural health is notorious for poor outcomes. It certainly, we have poorer outcomes than the standard care. But as a health center, we actually looked at the 10% that is the healthcare delivery system. And so our attempt has been to improve care by improving healthcare delivery. Next slide. And you know, within the context of that, we looked towards technology, both communication technology as well as information technology, to essentially eliminate the geographic isolation. And so to understand where our OB program is, we basically just wanted to present the other types of tele programs that are associated with our health center. And you know, I think it's, we've gotten recognition. We've done a pretty good job, but I think you have to recognize the fact that in setting this program up really requires additional funding and resources. And our TELE-OB program, when we set it up, was HRSA funded out of the Rural Health Office of Policy. And that grant gave us funding that then we could approach the Department of OBGYN and cover some of their costs to set up our telehealth program. Can I have the next slide? And you know, the other thing that Jared reflected on, and something I've grown to know as I've practiced in rural health settings, is that primary care in an urban setting is dramatically different than rural settings. And as people approach rural settings, the fact is the breadth of services are encompassing all aspects of care. It's not just primary care. And on any given day, urgent or acute care can often be outside of the scope of what primary care providers have been trained to do. We constantly are confronted with complex cases that are beyond our scope of training. And the attempt to maintain knowledge and quality across the spectrum with the patient problems is literally impossible to do on our own. And that, again, is the educational opportunities are limited because of the geographic location. So trying to address these issues is critical and certainly part of our OB program. Next slide. Yeah, so yeah, our OB program, and one of the aspects of getting specialists on board has been to model all of our relationship with specialists with certain premises. And the OB program followed our behavioral health integration with the Department of Psychiatry. And you know, it's as an internist, it's a little unusual to be presenting about OB, but in the setting of rural health, why we take on you know, a breadth of experience. And the first you know, the first component of setting up the relationship is that we set it up as a partnership, and the OB consultant is responsible for the quality of care of our prenatal program. So rather than having a consultant that basically makes recommendations, the consultant is an integral team member, and we share in the outcome of our prenatal program. The second is making sure that patients have a common understanding, and so to do that, one of the first things we did is to get all of the standard protocols and patient information that is shared with patients, and the you know, so that when we're talking to patients, it's consistent across the program, and the patients don't hear different things from the specialists than they do from the primary care providers, or if we switch off primary care providers, different things. Everybody's on the same page. That loneliness part is really critical too, and so you know, we contracted so that we have available consultations with the OB within 24 hours. This actually works much more efficiently than 24 hours. If a situation comes up where we need some assistance, while we text the OB, and they'll be back in touch with us usually in 2 to 3 hours, depending on their schedule, etc. But having that relationship and knowing us, they are very, very responsive to our needs as far as getting things straightened out for patients. Another aspect of telehealth, which is very important to keep in mind, is that face-to-face visits is a better way of setting up the relationship. When you have a relationship, well, then you can move it to video conferencing, but anytime you can have a face-to-face visit. And so we have our consultants come to Lana'i and both see patients, but also get to be meeting with the entire team so they can see how we operate, and that certainly lends itself to having them understand our limitations as well as our strengths. As Jared mentioned, our VTC meetings with the OB are monthly after the first trimester, and that can be more or less frequently. And then with the PCP in the room, why it's a triangulation, the care plans developed with the PCP. And you know, one of the aspects is that we make sure that we prescribe all the medication, and that's been very good too. We often prescribe medication at the recommendation of specialists. Sometimes we're not knowledgeable about that medication, but in the care plan, the specialist shares the risks and the benefits of the medication, what type of follow-up and what outcomes to look for. And having the primary care have all the medications, you know, reduces the chances of having conflicting medications from various different specialists. And then and as I mentioned before, and Jared mentioned, that participation of the PCP in the televisits is an essential component to the way we've set up our specialty care. As a medical director, that obviously costs more money because I've got a specialist or a primary care provider that is in the room, and we are not usually able to bill for that service, but it does keep primary care at the health center, and we generate additional visits quite frequently because we can follow up patients on our own and not have to have it referred back to the specialist. Next slide. Essentially, just briefly, to start the visit, we do share medical records. Unfortunately, we don't have the same EHR. That would be ideal. And we've been careful to make it easy for our consultants, so we have dedicated time in their schedule to do the telehealth visits. Having the PCP in the room is an essential component. We make sure that happens on all of our visits. The follow-up in between visits is important, and that's where the trust from the specialist comes in, because they are familiar with us and they are assuming that if things are not going well, they'll hear from us. And and this, as Jared had mentioned, has allowed us to keep all of the prenatal care on the island, except for some rare exceptions, as he mentioned. And that's been a real benefit in both attracting patients, but also obviously the ability to deliver high quality care. Next slide. I wanted to go through some of the technology that we currently use, and one of the aspects of the Lana'i Community Health Center is the use of telehealth. I've got 20 years experience in doing telehealth, but the introduction of Zoom and our ability to do the licensing and to own the technology to facilitate telehealth has really turned telehealth on its head. I mean, historically, it's always been a university or a large medical center that sets up a telehealth program, and the rural communities don't have control on how that is implemented. We started Zoom in 2014, and since we provide all of the technology, why we've been able to work out the relationships that work for both the specialists as well as for ourselves. We've become the hub of the telehealth, and it has allowed us to bring on specialists that only have to bring their communication device to work without having to do anything else. We basically set it up to have Zoom tested with one of their staff, and the next thing we know is we've got a telehealth visit. For OBGYN, once it gets established, why we just continue to provide those services. And with the context of the ultrasound, we started our ultrasound, I think, in 2015, and we got consultation from the Department of OBGYN to make sure we got the right machine and the right equipment. We wanted to make sure that it was able to do tele-ultrasound, and the StudyCast allows us to put it in the cloud, and Dr. Sai, who's the maternal fetal specialist, is able to read and interpret the ultrasounds and get back in touch with us in relationship to the readings on that. There again, we've asked them to look at the quality of our ultrasounds and give us feedback. We fortunately have a very high quality technician who does a very good job, and been providing really good quality care there. And we also have non-stress tests, which with high-risk pregnancies has allowed us to keep patients on the island for an extra week and save the cost of having to stay off island while waiting for the delivery. Have the next slide. And Yeah, looking at the future, yeah, the ultrasound has actually tied us into the specialists. And when the readings come through, why they know that we're managing them, and the maternal fetal specialist often will give us a call and talk about the complex patients. So this has been going on, for a number of years before we actually introduced Dr. Harai and the routine OB telehealth. But that co-management has led to really a real benefit in managing the high risk patients and substantially reduce the cost to our patients of having to travel off island, particularly when they're high risk. Next patient, next slide. One of the other aspects that directly applies to OB, but is a spinoff of our internal medicine chronic disease, is our Bluetooth-enabled remote monitoring, and this has become particularly important to the maternal fetal specialists now that we are in the COVID crisis. The remote monitoring uses Bluetooth-enabled blood pressure and glucose meters, and is able to upload through a smartphone or other device right into our information system, and is available through the cloud-based information system. So the management it's essentially getting vital signs from the home, so we can move from a office-based to a community-based management program. And we've moved to telehealth visits to the home with the COVID crisis. And to do this, we have looked at e-health literacy, the ability of our community to use technology. The younger people are a little bit better, but certainly our elderly patients sometimes have a hard time adapting to the technology. To improve our performance, our community health workers actually set up and work with patients to be able to transfer the information. And Jared had mentioned that they become involved with our high-risk prenatal care. They're trained in as health coaches, so they basically can participate in helping the management as well as being essential in getting the information and data back to our providers as well as the specialists. And I think the other thing, the first point there, one of the aspects that we're looking at right now with maternal fetal specialists is to be able to get real-time remote ultrasound imaging. If you have real time, then you no longer will need to have a technician at the primary care site, because these either technician or maternal fetal specialist will be able to guide the ultrasound image acquisition. And the technology exists right now. It's a matter of implementing that. We are lucky to have an ultrasound technician, but they may not always be available. And so moving to this higher level of communication technology is in the near future. Next slide. And I think that one of the real valuable things looking back at what we've done is the control element, that we have developed programs that made sense to us, were essentially logical in our setting, and we're successful at getting the collaboration of the Department of OBGYN and for them to be meeting our needs. And that starts with communicating a common mission and vision. And and understanding that the core value of the primary care setting when you're moving that forward. And it was also team-based care. It's where patients are shared, not, our patients are not paneled. Our patients are shared across the team, and patients understand that we're really focused on team-based care rather than having a primary provider that basically coordinates their care. And we've attempted to standardize care across our entire team. That also moves on to the treatment plans and the responsibility for quality. And I think I want to stress that emphasis that quality becomes a responsibility of everybody concerned, and we have mechanisms of building a quality program. And so looking at what we have, I would not recommend trying to move what we do to other primary care settings, but to keep in mind that every setting is unique, and the program development really needs to be developed by the primary care setting for their unique aspect in building that partnership. And at the same time, breaking down the specialist primary care is essential, but the specialists have to be active in imparting knowledge and building trust with the primary care provider to have a high quality program. But yeah, that learning process is a continuous activity, and has been invaluable for the way that we have things set up. And then, in using information technology and communication technology, those aspects really change the way we deliver healthcare. I mean, we have so much more going on at the community and home-based program with remote monitoring and everything. We're decreasing the number of times that people have to come to the office. COVID now allows us to do high-risk prenatal visits outside of the office, avoiding them coming to a place where they may get infections. And so that's a real transformation, but you have to keep in mind that technology is changing. We've got to figure out how to continue to use the advanced technology to benefit our care delivery system. So it's a dynamic step forward, but it's something that has to continually improve. Next slide. And I think with that, I want to share with you a picture of our team at Lana'i Community Health Center, and I'll turn it back over to Alice to coordinate questions. We don't need the other next couple slides will hold. Alice, thank you.
Great, wonderful. Well, thank you so much for sharing your experience. I think that was really helpful to hear. And we do have a couple of questions that have come in, both in the Zoom Q&A and a couple that were emailed to me actually. So if you have questions, please keep them coming in. You can see the little Q&A box that looks like little thought bubbles or conversation bubbles on your Zoom panel. So please feel free to send questions in that way. And I think you have the option of either doing it anonymously or with your name, whatever is easiest for you. So I'm going to start with this one. You talked a little bit about some of your community telehealth programs where people are accessing the technology from their home. Do you have people who do not have access to Zoom or who may not have access to phone or computer or internet? And how do you get around some of these barriers?
Yeah,
go ahead.
I'll take that and let Jared add to it. But yeah, we obviously have patients who do not have access to technology, and we actually did a study on e-health on who has what type of equipment in our community, and a very small a small number of patients actually had computers in their home. I think it was 23%. Most people are on tablets or smartphones. But then there is the problem of the phones not working because we don't have phone service in rural communities. we looked at technology as an enabler, not as a solution. We added our community health workers to basically solve problems of access to care. So they're able to be out in the community, and if it's a matter of not having the ability to hook into Bluetooth enabled information or the have a smartphone, they actually carry tablets and are able to upload information or to provide video conferencing. We do, most of our telehealth visits to specialists are actually at the office because it's a much better environment. But the community health workers actually are the major people that solve that issue and that problem. As we get 5G and move forward, why we'll have improving access, but at this time, why you have to be creative to address those issues.
Great. Jared, did you have anything to add to that?
Yeah, I guess the other part too is that in our model, we have the patients come to the health center for the appointment. Obviously, COVID has kind of changed things a little bit, but with our screening process here at the health center, we're still able to help facilitate having our patients come to the health center to access the telehealth here at the clinic, so the primary care provider can be involved. But for our very low risk pregnancies where they're not needed to come in, our tele will be as comfortable with having the patients join from home.
That's great, thank you. So you just mentioned community health workers. I know you talked about that in your presentation. So can you talk a little bit about the training that is provided to the community health workers you work with?
Oh boy, that is a real challenge in rural communities. And we've had 2 of our community health workers actually go through the KCC, the community college curriculum. They've got 5 different courses and a certificate for community health workers, which gives them, background. Obviously, the element of a community health worker is to hire somebody from the community that, inherently brings the communication skills. But in rural communities, you don't get people that have gone through the training courses, and so a lot of it is on-the-job training. We have been able to provide all of our community health workers with 2 to 3 day course in health coaching and smoking cessation, motivational interviewing, and so that we have that. I have to tell you, our community health workers have problem solved for getting the technology to really work. And a couple of them are younger and have done an amazing job of tracking down the problems with software applications and other things. I have worked with community health workers for years, and there is a huge amount of on-the-job training, certainly with pregnancy or with diabetes. Many of them have diabetes or had family members with diabetes, and so they bring an intrinsic knowledge with the community. And it's always been that it's easier. It's easier to teach a community health worker about the management of chronic disease and the elements that are important for patients than it is to train a provider to have real community or cultural sensitivity. And so that interface, often we see changes in the way that care is delivered because the ability to communicate is the critical element in improving the quality in the community, and the community health worker does that. You do have to, our community health workers are very comfortable in texting me or calling me at any time. You have to have, as with rural health, you have to have that support in, from the provider's perspective, and make sure we answer all the questions they have that might come from patients, and also have them understand their limitations so they don't go outside of their knowledge base to try to explain things to patients. So it's a challenge, but it is also a real essential element in the success of our program, and more so than the technology.
That's great. And it sounds like your model of team-based care is really set up for including the community health workers in the team too.
Yeah, they often are. We've tried to keep them in the room, and I've been actually doing telehealth from my home, and so the community health workers, we don't have another provider in the room, but the community health workers are always in there and always developing the treatment plan. So they're again a triangulation so that they understand where we're going with the patient. And anytime we have a complex pregnancy, often the community health workers will be in with our providers so that everybody's on the same page.
Great. So we've gotten, probably unsurprisingly, we've gotten a couple of questions in about kind of cost and reimbursement. So can you talk a little bit about the cost and reimbursement implications for coordinating with the OB or maternal fetal medicine specialist and the FQHC?
Always. Yeah. Yeah, we have been really fortunate in getting, grant funding. It would not be available without that, because our payment mechanism has not kept up with, with changing quality. We've got a quality program, and it is very difficult as a small rural health center to change the payment mechanism. So we're saving thousands of dollars, particularly for the Medicaid population. We save $10,000 a year in transportation costs because we have to fly people off the island for $200 a shot, and they were going off island, 4 or 5 times during their pregnancy to get ultrasounds or visit their OBs, and absolutely nothing comes back to us. So one of the reasons we're talking to you guys is maybe we can get some payment reform that looks at the benefit of changing the way we deliver healthcare. Because I think, Alice, you've recognized the fact that we are capable of doing that. We are working, certainly within the context of our Medicaid population, to be able to bill the FQHC PPS rate rather than have the specialist bill for the consultations, and then we've got an agreement to give them part of that. So we're basically beginning to look at payment mechanisms to allow this. As I pointed out with the circular diagram and the 10% that is the healthcare controlled aspect, quite honestly, we felt that the payment system and the pay for quality was going to be able to keep up with our dynamic change in the delivery system. That has not yet happened, but in a rural community, we felt it was there was a greater obligation to provide high quality care than it was to wait until the payment mechanism aligned with what we were doing. And so we continue to struggle with that. We, as I said, are able to compensate most of the time, but getting recognition for the program outside of recognition that you're doing a good job continues to be a challenge, and we are renegotiating our contracts. I think that the Department of OBGYN understands how important this is and the fact that it's a model that works, and so we are aligning other larger organizations that will be essential to basically change the reimbursement.
That's
I guess
great.
one thing I'll mention too is the reimbursement for telehealth visits in Hawaii is the same for face-to-face visits. So it's the same. I guess it's a level playing field in that regards. So.
Yeah, well, that's good news. So I think perhaps related to that, I did get a question in from somebody who's at at a state agency and wondering about how sort of states can help support this type of initiatives. If you have any advice for folks at the state level.
Yeah, I mean, I did put that last slide together because it is real. I mean, it is really a challenge to change the way we deliver the healthcare from a state level. You know, where you're actually not in the delivery system itself, but are often in the population system or the public health system. You know, our slide presentation in part was, you know, sponsored by the Department of Health because they had a telehealth maternal summit last October, and I think it was from Arkansas, the telehealth program from Arkansas. They were able to bring them in, and Lana'i Community Health Center was the second presenter on that. So I do think that you need to, the state level need to figure out how to facilitate and implement and possibly, you know, being able to address funding. From a state level, you also have a much better contact with the health plans. We're now working with maternal fetal health to try to use our software for monitoring hypertension and diabetes, and we've got a good response from the health plan because they realize that one sick baby is going to cost $100,000. If we get the software in place, we'll be able to deliver better care. And so I think at a state level, you know, it's, I mean, I've talked about sort of understanding the change model. You know, Cotter and other people have ways of changing the delivery system and bringing people together so that they understand that we actually have to better use technology for what it's there for. And there's lots of resistance to doing that, but the state may be able to be part of that solution rather than, you know, an observer.
That's great. So I see another question has come in about postpartum care. So can you please speak more to what your postpartum care entails for both your low and high risk pregnancies?
I'll punt to Jared for that.
Yeah, so on working with the tele-OB, we're able to kind of help facilitate that with anything that needs to be followed up. Of course, for those who've had gestational diabetes, we have them scheduled here at the health center to do their postpartum, you know, glucose check afterwards. And we also have in place to go ahead and already schedule patients when they do get back on island. We will see the baby for the newborn, you know, kind of well child check, and so we're able to kind of check in with the mother then and schedule a chance to have their postpartum checkup, get family planning on board, and all those kinds of topics too. And so, of course, if anything pops up that we need to get the tele-OB involved, we're able to kind of use that as well. And also, I know we kind of focused on the tele-OB, but I also will chime in that the obstetrician is also a gynecologist. So we also do provide tele-GYN, you know, consults. If there's anything that needs to be addressed in that kind of realm, we can help facilitate that. So we usually try to get our postpartum patients in, you know, for a follow-up about 4 to 6 weeks. And most of the time, the primary care providers are able to just kind of handle that. If any need we have to have the tele-OB involved, we can have that involved. But usually it's just with the PCP.
Great, thank you. So I'm gonna, we had a question coming in chat that Jared answered in the chat, so I'll just read it out so everybody can see that. How many clients do the community health workers work with at a given time? So Jared said we have 4 community health workers on staff and they work with about 15 to 20 patients each. And then a follow-up question to that is how long do the community health workers stay with the client?
Great question. Like Dr. Humphry mentioned, it's a very fluid kind of motion with the community health workers. We don't necessarily nickel and dime them on the time that they're with the patient. COVID has definitely expanded their role significantly for our elderly population. So our community health workers are actually doing a lot of work to help keep our elderly patients at home and kind of out of being around people. So I wouldn't say it's limited on how much time we keep with them. We really try to leave it to the community health workers to meet the needs of the patient, but of course try to use their time judiciously. Dr. Humphry, if you want to chime in on that too.
I would add to what Jared said. And one of the frustrations I've seen with case management or the concept that with social workers intervening, etc., is that they drop patients after they get stabilized. And our concept with community health workers is they can decrease the frequency, but they never lose the patient. That we want the patients to feel comfortable, because once they get better, they're probably 6 months from now going to be worse. And so, yeah, we have them permanently assigned to those, but they may not be in touch with those patients except for every 3 months or something if they're doing well.
Great. So we do have one more question that came in that I'm going to pose to you all, but since we're getting towards the end, before I tell you that question, I just wanted to point out for folks that may have to leave about our evaluation survey that I've also just put in the chat. I will also put my email address in the chat so that if you have any follow-up questions, you're welcome to reach out to me via email, and I'll make sure that those get to Jared and Joe as well. Okay, I'm going to go back to our other question that has come in. So this question is about, you talked about some of the practices that you've instituted in response to COVID. Do you envision continuing some of those practices that you've instituted in response to COVID once the pandemic has resolved?
You may take a stab at this one, Dr. Humphry?
Yeah, I can take that. Yeah. Yeah, I mean, I felt like somebody was going to accuse us of inventing COVID because we already had all of the elements in place to basically manage COVID before it actually started, and the rest of the community health workers and our community health centers and others are rapidly ramping up their telemedicine, and we already had everything in place. You know, our concept of delivering care through communication technology is that with remote monitoring and what we define as patient-generated information, which is that not only the blood glucose readings and the blood pressures, but the ability to do surveys and communicate electronically in between visits allows us to do episodic care without an office visit, and our community health workers are essential for doing that. They are in touch with the patients, and we often do medication adjustments or get labs, etc. You know, in between visits because of the way that occurs. So, you know, through communication technology, we can eliminate a lot of office visits. That's a disaster as far as your payment mechanism goes. But if you look at a hypertensive visit where a patient's doing well, they spend, take time off from work, sit in the office, come in, you check their home blood pressure monitoring readings. You've been getting that information on a continuous basis. You know the patient well, and there's nothing I would do in the office that I couldn't do, you know, with a video conference or even just through the community health worker saying that their management's good, because we're getting this episodic, it's not continuous monitoring, it's episodic monitoring, but it's much more timely for adjustment of medication. If I give somebody a new medication for hypertension, I can measure that in 2 weeks and see if the medication's working. I don't need to bring them back to the office. So yeah, COVID's accelerated telehealth, but you have to use the communication technology correctly. And my greatest fear is that it's going to be institutionalized for payment rather than for quality. And that people are going to, I mean, the best place for a physician or a provider to be working is in the office with good lighting, with all their tools, because that's where we were trained. But there's a lot of aspects of care that don't require that, and we can move those aspects to gathering information from home and doing that adjustment. So it's a way of thinking about the use of technology and not thinking about COVID, which is accelerated. If telehealth was so good, then why didn't we do it before COVID happened, which is what we did. We developed that. But anyhow, that's sort of the long answer.
That's great. Thank you all. So I think that's all the questions that we've had come in. I want to reiterate for folks who were able to stay on that you're welcome to reach out to me via email if things come up for you after the webinar. I will just ask if you all have any closing thoughts or things that you'd like to share with the group.
Well, no, I certainly appreciate the audience. I think the question on how we fund this, it's critical that we work together. And certainly I'd share with Alice that we are very much available to support and answer or work with any groups that want to work with us. I don't want to pretend we have all the answers, but our experience has been a very, very great learning experience. We know it's certainly know how to do this because we've made all the mistakes, and now we can sort of streamline it. And so if other people are interested in taking part in all of what we're doing, we certainly would like to be part of the solution across the broader spectrum.
Wonderful. Well, thank you both so much. We really appreciate your sharing your knowledge and your experience with us today. And I think we will certainly be in touch because I think that there's a lot of ways that we can all continue to collaborate in this space and others. So a big thank you to both of you for taking the time to present today and to prepare for the presentation. I also wanted to thank Cassie Phillips with HRSA, who helped set up the initial ideas for these and helped coordinate along with some of her other colleagues from HRSA. So we appreciate you all taking the time to attend today, and I hope that you all are all well and have a great rest of your day, no matter how many hours you have left in it. So thanks again to our presenters.